Good afternoon, ladies and gentlemen. Our webinar is beginning. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. We welcome you to this webinar. We thank you for attending this educational webinar that's hosted in coordination with Protiviti, an associate member of the Council. Today's topic, provider clinical quality and safety compliance. Protiviti is a global consulting firm, and they provide solutions that span all types of business problems related to technology, analytics, compliance, transactions, internal controls, and internal audit. Today, we have a trio of national experts to discuss quality and safety compliance. As you know, this involves a healthcare organization's adherence to established standards, all types of guidelines, regulations aimed at really helping ensure the delivery of safe, patient-centered care. And this includes implementing safety protocols, reporting adverse events, maintaining appropriate and proper documentation, and engaging in quality improvement. Our speakers today are Bryan Beaudoin, Associate Director of Health Information Management Solutions at Protiviti. We also are delighted that we've got Kim Pardini-Kiely, Director of Healthcare Operational Clinical Excellence, and also Kelsey Cavanaugh, Associate Director of Healthcare Data and Analytics. And we look forward to what we know is going to be an excellent presentation. One administrative matter, we know you'll have questions. Just please type them in the chat box or in the Q&A box. We'll monitor these and we'll answer them at the end of the presentation. But again, thank you for joining us. And with that, it's my pleasure to turn it over to Bryan.
Well, thank you so much. And thank you so much, all of you, for taking time out of your busy schedules to learn about a topic that should really be at the heart of every health system's mission, and that's really providing and demonstrating quality care, reducing preventable patient risks, and maintaining compliance with regulatory requirements. Our agenda for today will cover a number of topics. We'll dive into the OIG's requirements around quality and patient safety. We'll discuss quality. We'll also talk about the data pitfalls and how you can be leveraging data most effectively to drive your quality and patient safety initiatives. We'll dive more deeply into patient safety itself and what initiatives should be surrounding that to ensure your patients do not have preventable harm while in the hospital. And then we'll talk about compliance's role and the interplay between compliance programs and then the quality and patient safety programs. And then lastly, we'll actually discuss how clinical documentation actually plays a critical role in not only ensuring accurate coding, but also a critical role in ensuring accurate quality data and using quality data for instrumental change within your organization. As a quick introduction, as mentioned, my name is Bryan Beaudoin. I lead Protiviti's Health Information Management Solution, and a principal component of that is our clinical documentation and coding integrity efforts. And where that comes into play in this conversation is really going to be discussing how documentation may be driving some of those quality and patient safety initiatives and supporting them. Prior to coming to Protiviti, I actually set up clinical documentation integrity programs across the United States, so it's an area near and dear to my heart. I'm joined by two esteemed colleagues, Kim and Kelsey. Kelsey, I'll let you introduce yourself.
Sounds great. Thanks, Bryan. Hi, everyone. My name is Kelsey Cavanaugh, and I'm an Associate Director in Protiviti's Healthcare Industry Practice, where I specialize in healthcare innovation and analytics. I have over a decade of experience helping our clients build and implement solutions that turn complex data into actionable insights. And where that's going to be valuable for our conversation today is talking a little bit about common data pitfalls, how to avoid those, and how to use data to enhance performance improvement. With that, I'll go ahead and pass it over to Kim.
Yeah, hi everyone. Pleasure being here with all of you. So I'm Kim Pardini-Kiely. I'm the nurse of the group, and I've been with Protiviti for 6 years, leading our clinical and operational excellence work, and really working closely with both Bryan and Kelsey on implementing really good solutions based upon deep problem solving and the ideas developed to improve performance. I've been a C-level executive in the San Francisco Bay Area, so have that mix of both as a leader in quality, a CQO for an organization, as well as operational experience as a COO and CNO. So I think kind of bringing those together really help develop again those kind of implementable solutions for organizations. So with that, I am going to start and provide really an overview around. So the new requirements are that the compliance program partner and include quality and patient safety. So how did this come about? Well, in 2018, in a review that they performed around adverse events, what they found was that 1 in 4 Medicare patients actually experienced harm during their hospital stay. That level of harm, 12%, resulted in severe harm or more permanent harm. Things like certainly longer length of stay, permanent damage, life-saving interventions were necessary, and or unfortunately death. An additional 13% out of that 25% had temporary harm. And these were things that needed additional treatment, again, prolonging hospital stays. What's interesting to note is the most common harm was related to the administration of medications. The other types of events were things like pressure ulcers, procedures and surgeries, and lastly, infections, hospital-acquired infections. After the review that they did initially, they then had physician reviewers look at those same harm cases. And what they concluded was that 43% of them were actually preventable. So next, the OIG has issued guidance. This guidance was really temporary. It's not a requirement, but they are definitely looking at compliance programs for evidence that you're including quality and patient safety. And they also have recommended that organizations develop internal controls to monitor adherence to regulations and those program requirements. They really ask that there become integration between quality and patient safety with compliance, with the implementation of a system for regularly reporting, and that you educate leadership on how compliance actually supports and facilitates the management of quality outcomes. They recommend that compliance programs audit and monitor that improvements are achieved, and if not, why and what else should be done. And they work to ask that organizations incentivize reporting. I think oftentimes when you think about compliance programs, it's not just taking a quality report and then presenting that up through the board. This idea around auditing and monitoring the implementation is what's important. That really requires a conversation, and we'll dive a little bit deeper into that in a few minutes. So next, how quality and safety should be integrated. Well, they should not be distinct, right? Compliance sits over here, quality and patient safety sits over there. In fact, they need to be collaborative in many ways. because they're important, both of them, important parts of many regulatory bodies, such as Health and Human Services, CMS, the FDA, and obviously this came from the OIG and also the DOJ. So there's a lot of bodies looking at how well organizations address quality and safety related issues. The OIG also found in their issued corporate integrity agreements related to false claims that many of these false claims were in fact associated with quality of care issues. And these were things that compliance departments didn't necessarily understand or have knowledge of. And so if you have a number of false claims related to, let's say, longer length of stays because of pressure ulcers, then what is expected is that partnership between quality and compliance would facilitate that compliance knows that and could ask appropriate questions about what is being done and are we tracking to improve performance. Because this is new and because both had really existed in silos, the OIG really, to kind of help with all of this, have issued a number of toolkits. You can find that on their website, and that includes the board guidance on quality of care. And we'll talk about the fact that there is an expectation that compliance reports this up to the board. So next, there were specific OIG recommendations to CMS. These are actually the list of the hospital-acquired conditions that the OIG recommends that CMS include as part of a compliance program's ability to monitor. So example of monitoring are things like reviewing data and trends, looking for adherence to best practices. Example of that is high rates of infections that result in sepsis. Are the providers and clinicians really adhering to that sepsis bundle? So do you know that as a compliance program? That would be the expectation, and that you can further support, right, improvements in that. Also looking at adherences to best practices, things like frequent turning of patients to prevent things like pressure ulcers, implementation of falls protocols to reduce falls, and infection prevention practices. And those are just a few of the areas that could be looked at by the compliance program. Additionally, they really encourage the use of pilot programs and participation in demonstration projects as a way to effectively improve an organization's performance. And they've also provided the same guidance to CMS surveyors. So you can expect the CMS surveyors, should you have a CMS survey, and I was almost going to say unfortunate having a CMS survey, but we all know that, you know, certainly oversight is important to ensure that really adherence to some of these best practices. So next, the OIG also made very similar recommendations to AHRQ, which is the Agency for Healthcare Research and Quality. And they really emphasize the use of good reporting and the development of what they consider new strategies to prevent harm. And next, you know, harm really goes beyond the patient and their family. The patient safety net from AHRQ reported that the annual cost of preventable adverse events was estimated to be at about $17 billion. But that study really underestimated the total cost of adverse events, which, as they added that in, approached nearly $950 billion, or more than 40% of total healthcare spend. This relates to unnecessary treatment, prolonged hospitalization, harm events that resulted in the need for ongoing long-term care. The Joint Commission also released a report on the prevalence of second victims. And it was estimated that really nearly half of healthcare providers experienced an event that really resulted in them feeling as if they were a second victim. Additionally, a recent survey of surgeons revealed that 80% recalled having at least one intraoperative adverse event within the past year of their practice. So this prevalence is huge, and this collateral damage affects really the ability to continually provide high quality and safe care. So let me talk a little bit next about the overview of quality and really what encompasses quality. There are a variety of measures, but one of the things that I always recommend is starting with those that are publicly available. Compliance programs should be reviewing their organization's CMS outcomes and begin to ask questions with their quality collaborators around performance and what improvement efforts they have going on. Overall, what I would say is that the trend in quality is the move towards value-based care. This really means that value should be measured in terms of cost, quality, and service. And a program that really marries all of those elements is the most effective way for driving that performance for an organization, improving clinical outcomes, preventing harm, and ensuring appropriateness of medical care and how that relates to the overall cost. Next, this is where I say, data is king. And the importance of really understanding data. I don't think I can overemphasize that. A common adage that I often use is that you can't manage what you don't measure. And so data for quality and patient safety programs is really the basis for driving those improvements. So compliance needs to know how to interpret quality reports and to really understand that data as it's presented is presented in a way that presents really a good picture. I use this as a graph as what I like, which is the ability to look at care over time. It looks at directionality, statistical variation, and it's an important area for, I think, compliance programs to understand. And because it's so important, I'm going to turn it over to my colleague, Kelsey, who's going to give you some really great information about using data. Kelsey.
That's great. Thank you, Kim. So as Kim mentioned, on the topic of data collection and analysis, we'd be remiss if we didn't cover some of the most common data pitfalls. I'm going to go ahead and cover some of the most common mistakes that we see. Just know that each of these areas can significantly impact the reliability and the usefulness of our data insights. So being aware of these challenges really helps in delivering more accurate and actionable results. So before we dive into more of the technical pitfalls, it's really important to recognize that the foundation of any successful analytics initiative is clarity. Without clear goals and objectives, even if the most sophisticated analytics can fall short. The three most common pitfalls that we see here are unfocused analytics, lack of actionable insights, and undefined success metrics. So in terms of unfocused analysis, when we begin without a clearly defined purpose, we often end up with a flood of data that's difficult to interpret and even harder to apply. So to avoid this, project planning should start with identifying three different things. Who are the end users? What data is relevant? And what does the final deliverable need to accomplish? Really think about it as setting your GPS before starting. Just if you don't, just like in driving, you risk getting lost if you don't set that up front. This takes us to the second pitfall. Even when the data is clean and well organized, it's not useful unless it drives decisions. So before diving into your analysis, you should really start with a specific question that you're trying to answer, or a specific hypothesis you're trying to prove or disprove. For example, what factors are contributing to readmission rates within our cardiac unit? That one question becomes the lens through which all of your analysis is focused. And then as you keep that in mind, you should also make sure that every insight that you're gathering should be tied to a potential action, whether that's policy change, a training initiative, or a workflow adjustment. And really, the last piece is going back to what Kim said, you can't improve what you don't measure. So without defined key performance indicators, it's impossible to know whether your efforts are making an improvement. So your success metrics should be established collaboratively with the stakeholders during the planning phase, not retroactively. And so ultimately what this comes down to is that clear goals and objectives aren't just a planning tool, they're a safeguard against wasted effort and missing opportunity. So even after we set clear goals and objectives, analytics can fall short if the underlying data isn't reliable. We regularly see issues with incomplete data, non-standard formats, duplicate records, and missing identifiers or mismatched keys as we start to join data that's coming from different sources. Incomplete data can lead to blind spots in your analysis, and this is especially risky in clinical settings where missing some of this data could mean overlooking a trend in adverse events or patient outcomes. During data intake, it's really important to establish quality assurance processes to assess completeness and flag gaps early on so that they can be addressed before we start down the route of data analytics. In terms of formatting, when data comes in a non-standard format, whether that's variations in file types, so thinking we're getting data coming in from a SQL database and an Excel spreadsheet from your EHR, when it starts to come through in a non-standard format on a regular basis, that complicates joins and really slows down your analysis. And it often leads to extra processing time or increases the risk of errors. And so standardizing what format you're going to get data regularly upfront can save hours of cleanup on an ongoing basis and ensures smoother integration across the systems. What we've seen here is that building data dictionaries upfront can really help standardize this moving forward. In terms of duplicate records, so obviously those can inflate counts and distort your metrics. And so deduplication should be a part of your data cleansing process. And you can do this by using unique identifiers and automated checks up front. And then in terms of missing identifiers and mismatched keys, so as I mentioned, as we start to combine data sets from different data sources, having mismatched keys can cause inaccurate joins. And this is really, really common when you're merging data from different systems, especially if the systems weren't designed to talk to each other. So we should always validate our joins and make sure that the key fields are consistent and complete. And an easy way to do this is to really test your joins with a small sample set first and make sure that the relationships make sense and the data that you're seeing makes sense before scaling up. So even with clear goals and clean data, how we calculate and aggregate that data can really make or break the analysis. And so what we see in terms of pitfalls here are errors in aggregations, null values, inconsistent units, and percents. Aggregation, so that's doing anything from summing to averaging data to really summarize it and give us a good idea of the population, can be really, really useful. But if done improperly, it can distort the truth. For example, averaging across different patient populations or timeframes without understanding the data boundaries, like your minimum and maximum values, can distort what we're seeing. And so before aggregating data, you'll want to make sure that you understand the boundaries and ask yourself if the data points are comparable. Nulls and blanks can introduce bias if they're not handled. They do need to be accounted for, and how you're going to account for them depends on the context of the analysis. So in some cases, you'll use imputation or filling those blank values with based on certain criteria. Sometimes you'll exclude them, and sometimes you'll just make sure that they're flagged and clearly represented. It really just depends, but you'll want to make sure that you are handling those, as well as in the presentation, which we'll go on in a little bit further detail in a bit. You'll want to make sure that you're flagging those appropriately as well. Two of the other issues that we see, inconsistent units. So you'll want to make sure that for each of your metrics, you're using consistent units. So for example, length of stay, you'll want to make sure that you're not mixing days and hours, as that can throw off calculations. And then in terms of percents, just keep in mind that you can't simply add or average percentages like you would whole numbers. You'll have to consider the numerator and denominators as well. To the misinterpretation of data. And so this is really, really important. And this is where the human lens is important. You can use algorithms all day to identify data fluctuations, but you really need to take a look at some of these fluctuations that you're seeing to tell if they're meaningful or not. So first pitfall here is really related to correlation versus causation. This is a common trap in data interpretation. And for example, say we notice that units with a higher nurse to patient ratio also have more patient falls. That's a correlation. It does tell us that there's a relationship, but it doesn't exactly tell us the cause. It could be that those units have more complex patients or that staffing ratios are adjusted reactively after incidents. To prove causation, we'd really need to dig a little bit deeper through things like time series analysis or controlled comparisons to see if the changes in staffing directly reduce fall rates. And patient safety, really jumping to conclusions without confirming causality can lead to ineffective or harmful interventions. The second pitfall we see here is common cause versus special cause variation. With variation, not all fluctuations in our data are cause for alarm. Common cause is the normal fluctuation in a stable system, such as hospital-acquired infection rates hovering between 2 to 3%. However, special cause variation signals something that we don't expect or something unusual. And that includes, in that example, hospital-acquired infections spiking to 7%. That could indicate a breakdown in protocol, like a sterilization protocol failed or a new device was introduced without proper training. And so control charts, which Kim showed earlier in her slides, can really help distinguish between common cause and special cause variation so that we don't overreact to normal noise or underreact to real problems. And then lastly, data distribution does matter. Averages don't always tell the full story. So imagine we're looking at patient wait times in the emergency department. If most patients are seen within 30 minutes, but then a few wait 4 to 5 hours, the mean might suggest a 90-minute wait. However, that doesn't reflect the typical experience. In this case, a median or even a full distribution chart would give us a clearer picture. So before diving into the analysis, we should always check the shape of the data and use tools like standard deviation and outlier analysis to really understand the data variability. And then finally, moving into data presentation, this is where the data presentation to the stakeholders is extremely critical. We can have the most accurate, insightful analysis possible, but if it's buried in cluttered charts or overwhelming spreadsheets, the message can be lost. So some of the pitfalls we see here are misleading visuals, so having inconsistent scales, missing labels, or vague axes can be an issue. So always make sure to include clear labels, data sources, and timeframes. The other pitfall that we see here is just making sure that you're always aware of the format. So you should be matching the chart that you're using to the story. So to start, ask yourself what question that you're trying to answer. As some examples, use line charts for trends over time, bar charts for category comparisons, control charts for spotting outliers or distinguishing common cause versus special cause variation. Ultimately, how we present the data determines whether it sparks understanding or gets overlooked. When the data is clear, contextualized, and tailored to the audience, it does become a very powerful tool for change. And so the next step is using that data to really drive performance improvement, which Kim will speak to on our next slide.
Great. Kelsey, thanks so much. Really helpful information. So we've reviewed really why and how compliance needed to incorporate quality and patient safety into their program. We've talked a bit about the importance of data and how best to analyze it. And now I'd like to give you a little bit of insight around just how, in fact, compliance can promote performance improvement. I always like to start and talk with many of our clients around quality that performance improvement is a science, and it is a science based upon the use of data to provide insights, and a science in being able to identify what the real problem is. One of the things that struck me about what Kelsey was talking about is you can't just, take a data source and think that you know what the problem is on the data. You really need to understand what directionality or what those data might be telling you in order to be able to provide insights. An organization really also needs to understand, the fact, and the board also, the complexity of healthcare, right? That makes it really important to make sure that your data is telling you the right story and that your performance improvement has been able to adequately and accurately identify what the problem is. Involvement in all of the hospital departments or healthcare organization departments, both inpatient, outpatient, beyond home healthcare, all of these is really dependent upon their ability to understand and to be able to implement performance improvement. So it's incredibly important to have a very strong, well understood model for performance improvement. There are a variety out there. High reliability organizations, the Institute for Healthcare Improvement has models. There's the standard PDCA, Plan, Do, Study, Act. There's Lean, there's Six Sigma. All of those certainly are well-known and well-tested models, but I think it's really dependent on an organization, and in this case for the compliance program, to really have that deep knowledge around what the model is and what the expectations are around how that model is being utilized. So next, let me talk a little bit about patient safety. Really, this is certainly near and dear to my heart, but it is important for organizations to create a culture where mistakes are learning opportunities rather than punitive. And a just culture really helps to encourage error reporting, to allow really your organizations to learn from their experience and to identify contributing system factors. Errors that cause no harm are just as valuable from a learning perspective as those that result in harm. And trust is really crucial in developing really that effective error reporting system. If the outcome of error reporting is seen as punitive or it's labor intensive, you're going to miss many of the opportunities. So individuals need to be able to trust that they can report issues without fear, and that really a just culture model comprises really that irreplaceable framework where administrators, employees share in the responsibility of maintaining safe practices and minimizing errors. That is dependent upon leaders, and this includes compliance, to really be able to articulate their model of a safe culture and measure that. So use of, culture of safety surveys are an important tool to help really identify how well staff feel. I often, in many of the work that I do around patient safety programs, is I go on site. There's nothing better than being able to talk with staff and physicians about how safe they feel reporting and how easy the system is for them to use. Ease is going to be really critical, because if it's not easy, then it won't be well utilized. Additionally, understanding what the categories are associated with your reporting is very important. Are you able to get at some of those root causes? And is it easy enough to find those in some of your drop-down menus when you're doing event reporting? So next, let me tell you about how I see compliance programs incorporating quality. And I think first and foremost is transparency. Compliance programs really must ensure that quality concerns are being reported up to the executive team and to the board, and really in a way that is well understood by those parties. A strong quality and safety program needs to also include looking at medically unnecessary services, and that can lead to often overpayment and a false claims liability. So again, you can see that really strong connection between quality and compliance. I think what would be helpful for compliance programs in meeting with quality leaders is to make sure that they evaluate the effectiveness of action plans. And this means, is there a way to monitor that action plans have been fully implemented? It also should define who has that responsibility. And I think most importantly, and often most overlooked, is, do you have an effective mechanism for monitoring whether or not there is continued effectiveness of those action plans or adherence to any process or practice changes that occur as a result of some of your events? A suggested approach really is to include quality and patient safety leaders in compliance committees, to have routine meetings. Certainly quarterly, I think, is probably the best way to put those together, and to include quality and patient safety and compliance risk assessment activities. I think the compliance program needs to understand what are the priorities for the quality departments about events and PI projects, and then really to support that work, ensuring that there's dedicated structures to conduct quality and patient safety activities. Next, I'm gonna talk just a bit about, it all rolls up to the board of directors, and their role is to ensure that there are adequate resources available, is really part of their overall fiduciary responsibility. Making them aware of quality and patient safety outcomes is also important. And one shouldn't shy away from where there are opportunities. I think there's always a tendency to present all of the great stuff that organizations are doing to the board. Don't disagree with that at all, but should also include where there are those gaps in performance. There's typically a quality subcommittee of the board, and there's a similar structure for the compliance committee, but both should be aware, and I think working together to ensure that organizational goals are met and quality outcomes are really achieved. That's often accomplished through the use of board dashboards that are easy to read and understood by the various board members. As a former quality leader, I would often summarize quality and safety activities, highlighting our performance and where those opportunities were, and would then have a discussion with my compliance leader, and the two of us would be in sync, understanding about how well our improvement efforts were working. Once these activities are really supported and endorsed by the board, then it becomes easy to establish that culture of safety and the culture of really continual performance improvement. All of this is equally based upon the ability to be able to pull out, as we talked about, that information. So where that comes from, I'm going to turn it over to Bryan to go over.
Thanks so much, Kim. Yeah, as you heard, Kim discussed extensively performance improvement initiatives and data that is driving quality and patient safety initiatives and reporting. Kelsey extensively talked about data analytics, which help develop and drive and provide ability to make informed decisions around those types of initiatives. But what I really think is important is understanding what data sets actually are being leveraged to make all these decisions, what's being analyzed, for example. And by and large, it's actually medical coded data. Medical coded data by quality departments, compliance departments, et cetera, to identify potential issues or to identify potential trends. It's also used by CMS and other organizations when they're conducting their analyses around potential, let's say, preventable conditions. One key concept of medical coded data is that it is driven entirely by provider documentation. If the provider documentation is not clear, concise, and able to be effectively coded, then we have issues when it comes to the coding, which then drives issues when it comes to the actual data analytics. I want to hone in on one area that I think is really important, especially when it comes to quality and patient safety. And that's what's called present on admission documentation. So present on admission is really just what it sounds. It is documenting using specific codes on the claim that states whether a specific IC10-CM code or a diagnosis code was present or not when that patient came into the inpatient environment in a hospital. Almost all, or at least the vast majority of diagnosis codes require a present on admission notation next to it, and that is required by CMS. There are a few key kind of present on admission indicators. So the two big ones are obviously, yes, that particular condition was present on admission. A great example is a patient came in with a respiratory condition. They also had chronic kidney disease, for example. Documenting that that is present and was not developed in the hospital is key. And that would be a Y. The other option is just the reverse, no. So a condition was not present on admission, but was developed in the hospital. Let's say a patient had a surgery and they either had a postoperative infection or postoperative hemorrhagic anemia. That was actually developed at the hospital. And those are really important when we come to something called HACs and PSIs, which I'll talk about in just a second. The other two options, which are largely less used, are unknown. So it's just not known, for example, with the documentation if a particular condition was present or not, like a patient's mental status, or clinically undetermined. The provider himself or herself does not know if that particular condition was present when the patient came in, such as chest pain. Maybe that was developing in the ED, for example. As I mentioned, this data is really important for what's called HACs or PSIs. So HACs are hospital-acquired conditions and PSIs are patient safety indicators. And together they represent types of events or types of diagnoses or complications that really CMS has deemed should not have occurred through the normal course of care and are typically the result of some sort of a breakdown or failure of patient care. Some good examples would be a pressure ulcer developed because the patient was not turned enough, a catheter-associated infection because a catheter was not sterilized effectively and the patient developed an infection, or even the example you hear about sometimes, which scares anyone who goes into surgery, a foreign object left within the body after surgery. Those types of things, as well as a variety of other types of infections, et cetera, CMS not only will not pay for, but they will ding you when it comes to your quality ratings. And why this is so important, or why POA is so important, is because if you do not get the POA correct and notate if something was present when the patient came in, you are likely to be dinged for something that really wasn't your problem or your fault in the hospital care. So an example is a patient comes from a long-term care facility, with an upper respiratory infection. During the course of care, there is a notation that the patient has a stage 4 pressure ulcer. It's actually not effectively documented, yes or no, whether that came from the long-term care facility or developed at the hospital. If that's not actually documented correct, it's often assumed that the POA is yes, and the hospital get dinged. However, if it's clear that the patient had this pressure ulcer when they were at the long-term care facility and it came into the hospital with them, then obviously would not ding the hospital. So that is some of the key concepts around present on admission and how that flows through towards quality reporting of those types of conditions, which in all rationale really shouldn't be occurring during, effective care for a patient. If we go to the next slide. Beyond just those hacks and PSIs, I do think it's important that we notate that Present on a Mission has some other impacts. First, it outlines and highlights the baseline conditions of patients. So do they have specific comorbidities like heart failure or hypertension as they came into the hospital? Are those things that are being developed? That information is important for a variety of reasons, including care continuity. It also impacts quality metrics. So a hospital can't effectively identify if they have a significant spike or trend when it comes to CAUTIs or catheter-associated UTIs, if it's not clear that those particular conditions were not present when the patient came in. If you can understand that, yes, it seems that we have particular facilities that have a higher rate of CAUTIs that are occurring at that facility and are not because they came in with that particular condition, you can then effectively determine how to develop protocols to prevent that moving forward. And also just reduce the risk of penalties. So if you're not capturing that information, like I mentioned, you can get penalized for particular types of conditions like hacks or PSIs, or you can get penalized just for incorrect documentation as a whole around specific conditions. And as we mentioned, it impacts patient safety initiatives, especially around particular conditions that may interplay with other conditions like hypertension. We can move to the next slide. Beyond the POA, I do think it's important that we talk about capturing conditions to the highest level of specificity. So coding guidelines outline that every specific condition needs to be captured to the highest level of specificity. An example would be saying patient has heart failure. Well, do they have chronic or acute heart failure? Do they have diastolic heart failure, for example? Capturing some of that key information really allows for better visibility into the patients coming into your hospital and the types of conditions they have, and allows to potentially even determine where resources need to be allocated because of specific conditions that are more prevalent that need to be treated within a hospital. It also supports regulatory compliance. So a great example is often we will see unspecified codes either being denied because they don't clearly demonstrate the medical necessity of services being provided associated with an unspecified diagnosis, or they may be audited and CMS or the OIG, your MACs, your Medicare Administrative Contracts may come back and say, you know, you did not document or code effectively this particular condition. We don't think that it warrants a specific type of payment. We're going to ask for some of that money back. And it also impacts what we call risk adjustment. So if you're an organization that is part of an accountable care organization, or if you have a Medicare Advantage plan, capturing to the highest level of specificity impacts how these patients are risk adjust in terms of the likelihood of needing more resources throughout their particular beneficiary year. Without that information, it may look like you just serve a whole bunch of very healthy patients and you don't need as much money to be supporting them. If we go to the next slide. The last thing I think is really important to highlight, and that's really what we would say are some of the compliant or non-compliant documentation practices by providers that really a compliance organization, a CDI function, revenue cycle, HIM, all should play a role in making sure that we discourage. So some of those examples would be a provider who is copying, pasting progress notes from a previous day without actually reviewing them and editing them to reflect what's going on with that patient that day. Or a provider who is copying another patient's or another provider's notes and then making minimal changes to them. Or what we call pre-charting. A provider or someone has, maybe it's a mid-level, has pre-charted some of what's going on with that patient before even seeing the patient just based off of what they're seeing. Well, what happens if that particular patient never gets seen by that provider? Now you have a medical record that's associated with no actual encounter. Or you have instances in which documentation really didn't reflect what was going on with that patient, which can impact continuity of care, and it can also impact documentation around how that patient is doing. A good example is looked at a chart in which a provider had copied the same progress note over 5 times. Well, in the initial progress note that they copied, that patient had a ground level fall. It now looks like that patient has fallen 5 times each one day. That obviously does not look good. It also erodes patient trust. More and more now, patients are able to see their own medical record and really validate that what was documented aligns with what they assume was their experience. And if they are seeing incorrect information, you obviously have an issue where providers and patients don't have that same level of trust. It can also impact patient care. Let's say for some reason a provider is copying the same progress note or is not documenting to the highest level of specificity. They may not be copying a specific condition that is developed a particular day. That information, if it's no longer in the medical record, is no longer available. Let's say when a hospitalist rolls off and a new hospitalist comes in to see that patient, or that patient leaves and goes to another facility, maybe they're discharged, and that information is not in the record so that the next provider can make informed reduction needs. We've even seen examples where specific medication allergies were for some reason not captured, and that patient could potentially be exposed to those types of medications that they're allergic to, resulting in potential serious harm. And as you can imagine, all of this puts an organization at significant legal and audit risks. If an external auditor sees this type of practice, they are likely to question everything about the documentation they're reviewing and have a high likelihood to say that they do not believe that you should have been paid for those types of services. All of this also drives back to quality initiatives. If the documentation is not accurate, the coding is not accurate, all of the data that's being analyzed and sophistically laid out for key decision makers may not be accurate itself. So with that, kind of conclude some of our concepts around provider documentation, and we want to open it up for Q&A.
Thanks so much, Bryan, Kim, and Kelsey. What a great job. You really covered a lot in the time we allotted. Again, if you have questions, please put them in the Q&A or the chat. I will say I had a couple of advanced questions that people sent in. You know, in hospitals, as you well know, especially those of you that have worked in hospitals, people are really busy. So what are some effective ways to engage clinical and quality leaders to serve on compliance committees? Any thoughts on that?
Yeah, let me kind of weigh in on, I always find that the most successful way to garner engagement is to really be on the same page, to understand what drives people to go into healthcare in the first place. And so kind of using that importance of providing the very best care, I think is a way to get that level of engagement. The other thing is that I promote the use of audit and compliance as really a very effective mechanism for getting an organization to really embrace the kinds of improvement activities that are necessary to improve performance. And so that level of visibility, I think, is a great way to get people to understand how they, sitting on those committees, can really be, I think, part of solutioning for organizations and bring that level of clinical expertise to them.
So, Kim, a follow-up question to that.
Yeah.
You brought up a very good point. Once you get the people engaged, and you did emphasize, looking at compliance, looking at internal controls, what type of effective forums would you recommend to bring in and collaborate with quality and patient safety leaders?
Well, one of the things that I prefer are meetings, right? So that's where we all kind of live, right? Is in meeting world. But that meetings are really more about looking for solutions, really understanding what problems are. So I often encourage organizations to look at the format of their committees. And what I see a lot is simply reporting a number of things. At the end of that, is there anything else we need? Okay, yeah, we'll assign that to somebody to maybe do follow-up. And that's the end of it. And when you go, minute to minute to minute looking to see, is there a thread that goes through? It doesn't exist. I also like to say the work of committees happens in between the meetings. So it's going back and really following up with whoever and whatever expectations were set, really based upon that thorough problem solving and coming up with good actions. When there are forums like that, people like to be involved in that. I was just on a recent committee meeting where all of the providers were allowed to vote. So that sense of absolute engagement occurred because they knew they had a voice there and that it wasn't just listening to reporting, it was actually problem solving.
Kim, that's a good point. I worked in hospitals for 35 years before I came to the hospital council. And, you have to have risk management, you got to have compliance, you've got to have internal audit, and they have to work with operations and they have to work with the teams. They have to audit, they have to make sure people are in compliance, but you have to do it in effective constructive ways. So in your experience, how can compliance really monitor the completion of patient safety event action plans? And if there are deficiencies, how do they proactively work collaboratively to correct them?
I think going out where care is being delivered. You can't sit behind a desk, look at a report and say, was this implemented? And get an answer back that said, yes, it was. And here was the date, that we did education, so to speak, right? It means going out to the units. It means going out to where care is being delivered and saying, okay, tell me about your experience with what you're doing to reduce patient falls, for example. And that's where you get your insight, is going to where it is actually happening.
Good point. Really, you have to make rounds. Really, you have to get out where the action is.
Yep.
Bryan, you mentioned, and it was a good point, how the OIG makes recommendations to CMS and to AHRQ. And sometimes that helps shape future compliance strategies. And you don't have to answer this. It's really to all three of you. But as you see the changes in CMS now, do you see any shift in how those recommendations can really shape future compliance strategies?
One of the shifts that we had seen, recent years was really a focus beyond just the inpatient stay, but looking at how patients are being evaluated across the care continuum and even outside of the care continuum. So things like social determinants of health. How are we capturing and acting on those? There is a big push towards those. In fact, there's new financial incentives for capturing some of the social determinants of health, like homelessness. And that really should be something that compliance departments are thinking about and actually evaluating themselves, because it ultimately protects the organization through avoiding unnecessary admissions, and it protects the patients throughout their time in and outside of the hospital. Kim, anything you want to add?
No, I think you covered it, Bryan. I think that's absolutely true, that there is this push across the continuum because, it's care is not a single point, right? It is multiple points across time.
And one thing I just quickly add, the enforcement agencies have gotten really, really good at advanced analytics to identify potential, we'll call them bad actors or, aberrant billing patterns, and compliance departments, auditing departments. All of them should really be thinking about how they're implementing that type of analytics to be proactive, or they may be caught off guard, especially now that these organizations are much better at combing the data to look for potential risk and going after it.
Great advice. Y'all mentioned president-owned admission. Boy, president-owned admission from a patient safety point of view. Based on your experience and based on facilities you've helped in your practice, what do you think are some of the best analytics hospitals can perform to see if they're accurately capturing present on admission?
Yeah, what I would recommend is, so for example, those hacks and PSIs I discussed, those are all tied to very discrete ICD-10 codes. You can look up the codes that are associated with those, and you can ask your data teams, whoever, your revenue cycle teams, to run an analytics that says, give me all of the claims in which these particular types of diagnosis codes were reported, and the present on admission was either Y or N. Specifically focus on those that are N, so not present on admission, and do a very targeted review to see if maybe either there's an issue with the provider not documenting effectively if a condition was something the patient came in with, or if maybe coding's getting it wrong. Maybe they're just missing some of these, and you need to do some serious education and targeted auditing of those areas. So you can use the ICD-10-CM codes. They're standardized around every claim, and then marry that up with the specific POA codes.
Excellent. Well, Bryan, Kim, and Kelsey, what an excellent presentation. This has been very informative, and I know the people participating in this webinar are very appreciative. Before we close, I'll turn it back over to all three of you for a final word, and I'm assuming it's okay if Chris shares your presentation with the people that registered for this, but I wanted to make sure we had your permission.
Absolutely.
Yep.
Yeah. And I think anybody can reach out to us as well, and we're happy to answer any other specific questions that maybe you didn't want to bring up in this broader group. So we're here and available for all of that. Our goal is to really help organizations be the best they can be and really provide outstanding care to all of their patients. So that's our bottom line.
That's a great bottom line. For those of you that do want to reach out to Bryan, Kim, or Kelsey, just contact Chris Wilson. He's got their email, and he'll make sure that he puts you in contact with them. But Bryan, Kim, and Kelsey, on behalf of all the people participating on the webinar and the Dallas-Fort Worth Hospital Council, thank you for this excellent webinar. And this now concludes our webinar, but everyone have a great rest of the day. Thank you.
Thank you all.